Thank you very much to Dr. Guerin and Dr. Langer for inviting me back to speak. I hope you'll enjoy my talk and I'll get to return for many years to come. My name is Jonathan Goldman. I'm a professor at UCLA, associate professor. Here are my disclosures. I have the pleasure of speaking on current controversies in small cell lung cancer. We'll be talking about prophylactic cranial irradiation, consolidation with chest radiotherapy, and second-line therapy. To review, prophylactic cranial irradiation is considered because it has been known that small cell lung cancer is very radiosensitive and has a high propensity of metastasizing to the brain with associated significant morbidity and mortality. Several trials have identified an optimal radiation schedule. More than 36 Gray was shown to increase toxicity and mortality. In fact, therefore, 25 Gray and 10 fractions is considered optimal, although there are some slight variations that are considered acceptable. However, even at the optimal dosing, neurocognitive toxicity is common. It depends significantly on how it is measured, but even at the 25 Gray schedule, 62% of patients were identified to have neurocognitive toxicity if measured carefully. This trial looked at 4 different tools, and a decrease on at least one of them was considered a decrease in neurocognitive function. Younger patients do a little better, but patients over 60, 83% of patients had neurocognitive toxicity. This can be seen with a reduction in interactivity or processing. I notice my patients do tend to be a little slower to laugh at a joke, for example, and perhaps I have to work on my jokes. Several attempts have been made to try to improve this toxicity. Memantine during and after radiotherapy was suggested to be neuroprotective. The pivotal trial by Brown, however, was negative at its primary endpoint at 24 weeks, but here we have the curves of neurocognitive function failure, and you can see that over time it does seem that memantine has a potential benefit. Alternatively, hippocampal sparing PCI is under evaluation. At least 4 randomized trials of hippocampal avoidance have been done. Not all of them, but some have suggested neuroprotective effects and no increase in brain metastases. Importantly, an NCI RTOG study is currently accruing, looking at both memantine and hippocampal avoidance. Now we'll look at the efficacy side. In limited stage small cell, with a good response to initial therapy, evidence has suggested that PCI both decreases brain metastases and increases overall survival. There are 2 trials that or 2 manuscripts that I'd like to highlight. The Ariagata trial showed a reduction in brain metastases from about 59 to 43%, and also an improvement in overall survival, an absolute improvement of 3% at 5 years. Here you see the quite dramatic improvement in brain metastases, as well as the incremental benefit in overall survival. The second is the New England Journal meta-analysis, and importantly, I'll note that both of these trials are from many years ago, both of these reports. In the meta-analysis, you can see here the forest plots showing a clear improvement in brain metastasis and overall an improvement in death with a 16% reduction in the risk of death and a 5% improvement in absolute improvement in overall survival at 3 years. None of these trials, though, included MRI imaging, and so although they are still considered pivotal, one may question whether they apply in the modern age. And this SWOG trial that I mentioned on the last slide will be very instructive, and hopefully we'll be able to accrue effectively. Even more controversial, I would say, is in the extensive stage. The EORTC trial reported actually at one of my very first ASCO conferences in a plenary session, randomized 286 patients, and a dramatic improvement in brain metastases, more than 50%, and an improvement in disease-free survival and overall survival associated with a 1-year survival improvement from 13 to 27%. Here you can see the curves with brain metastases on the left and overall survival on the right. However, even at that plenary session, questions were raised regarding the imaging modality. It was CT scans. And in fact, a CT scan, no imaging was required after at the enrollment into the trial, at the end of the induction chemotherapy. Therefore, one may very readily question if it applies to the current treatment standard of care. So a Japanese trial by Takahashi et al. Randomized just about as many patients. And in fact, here you can see in the middle is brain metastases, which look improved, but progression-free survival was unchanged. And in fact, overall survival, not significantly different, but numerically decreased with PCI. So one may certainly question the benefit of PCI in extensive stage disease. We'll now move on to consolidation thoracic radiation. The concept is local therapy, even in extensive stage, for patients that get a complete response or a good response to systemic therapy. Several trials have shown that consolidation thoracic radiotherapy is well tolerated, possibly fewer symptomatic chest recurrences, and possibly improved survival. The earlier trials were small, but they all show no overall survival benefit, and one, in fact, with a decrement, a non-significant decrement in overall survival. This changed with the Duramic study of 210 patients, again, enrolled many decades ago. These were patients who did well in the thorax, CR or partial response, and had a CR distantly. They were then randomized to concurrent radiotherapy with cycle 4 or not, groups 1 or 2. And here we can see the curves. Groups 3, 4, and 5 are patients that did not do as well with systemic chemo, and you can see that their survival was actually clearly quite poor. But among the patients in 1 and 2, getting the thoracic radiation in this trial was associated with an improvement in overall survival of 17 versus 11 months. This was followed by a small yeast study, which also suggested an improvement, single-arm study, but compared to historical controls, suggested an improvement in symptomatic chest recurrence. Again, Slotman et al. Stepped in with a potentially definitive study called the CREST trial, about almost 500 patients treated with a slightly lower dose of 30 gray and 10 fractions. And here I think the statistics are very important. The primary endpoint of 1-year overall survival was negative by the p-value, but other endpoints like 2-year overall survival and 6-month progression-free survival were considered positive. There was also a post hoc analysis of patients with residual thoracic disease, and that also was considered to be positive. However, here's the curves in the forest plot. However, I think in the last years, clinical researchers have learned a lot about statistics. I'm sure we have a lot left to learn, but we have certainly learned this, that a p-value of less than 0.05 does not necessarily mean that there's a greater than 95% chance of the finding being true when it is not the primary endpoint, especially when it is post hoc. You're not allowed to keep on making assessments until you find a positive one. I think this really does call, in fact, many of the trials in this field from decades ago into some question. The other additional factor is the two pivotal recent trials, Empower 133 and Caspian, showing the addition of immunotherapy to chemotherapy for first-line extensive stage. Those trials did not allow consolidative thoracic radiotherapy, making its role further uncertain. So in summary, I've put together my thoughts on radiotherapy in small cell lung cancer. On the left here, I have the algorithm from Karen Kelly in Up to Date, which I think is quite excellent and I agree with in many regards. So we'll begin from the clearest or early in disease to later, and also in more clear evidence suggesting benefit. So adjuvant mediastinal radiotherapy for those few patients that do get to surgery and have lymph node positive disease is indicated. Stereotactic body radiotherapy, SABR, for an early stage disease in patients that are medically inoperable is also considered very appropriate. Concurrent radiotherapy for limited stage, obviously well understood to be an important aspect of care. Whole brain radiotherapy, occasionally stereotactic radiosurgery for CNS metastases, palliative radiation for bony metastases or SVC syndrome. And then we get into the controversies. PCI, I believe there's more evidence in limited stage than an extensive stage, but given particularly the factors regarding imaging modality and the lack of modern surveillance for brain metastases, the benefit in either setting can be questioned. I've gotten to the point that in general, in extensive stage, I'm not recommending it. In limited stage, if a patient wishes to decline brain prophylactic cranial radiation, I don't argue with them. An alternative is CNS surveillance by MRI instead. And then consolidation thoracic radiotherapy could be considered in certain very good responses, but with residual thoracic disease, we are often looking at the scans with the radiation oncologist, and if there is disease in the chest, for example, considered to be at high risk for causing SVC syndrome in the near future, we are offering radiotherapy in that setting, although it is difficult to think about exactly how to intercalate that with immunotherapy, and perhaps can be done early on between cycles. Now moving on to second-line therapy, I would consider this less an area of controversy and just an area where we need more options and more data. Following NCCN, I've listed here some of the agents that are indicated for patients if they have platinum-resistant disease with a relapse less than 6 months, or platinum-sensitive with a relapse after 6 months. In the earlier recurrences, Topotecan, either oral or IV, Lurbinectedin, and of course clinical trials are highly recommended. I've also listed some of the other agents that can be considered, which we'll review a little bit more shortly. And then in later relapse, we now have a nice trial just reported earlier this year in Lancet Oncology, showing that returning to platinum doublet does outperform Topotecan by progression-free survival, not by overall survival, but progression-free survival, and was better tolerated. And Lurbinectedin also has evidence in this later recurrence patients. So beginning with Topotecan, we all know the trial comparing to CAV. Here's the curves showing a similar response rate, progression-free survival, and overall survival, but with better symptom improvement and less toxicity. In fact, the data for the oral Topotecan is a little bit stronger compared to best supportive care, a survival benefit of about 3 months and greater symptom control, and another trial compared PO to IV to PO Topotecan and saw no difference. Lurbinectedin is the new drug on the block, approved earlier this year in the spring. It's described as a selective inhibitor of oncogenic transcription, a phrase that I have to read several times to try to understand exactly what it means. I think if you look at the toxicities and compare it to the similar drug trabectedin, perhaps it should be best considered as a cytotoxic, but maybe that was considered a passé type of cancer therapy. The drug is given IV every 3 weeks. In the single-arm trial, the response rate was 35% and duration of response 5.1 months. Patients with platinum-sensitive disease did better than the platinum-resistant patients, but both appeared to benefit compared to expectations. The toxicities were mainly hematologic, relatively high rates of neutropenia and febrile neutropenia, and therefore growth factor support seems very reasonable. Other second-line agents, many of these trials were, nearly all were less than 50 patients, and I'd like to suggest that the differences in response rate are probably more due to the small size of the trials than great differences in the agents, but I will highlight a few of the drugs. Paclitaxel is one of my preferred options in this setting due to the ease of its administration and good tolerability. And in fact, in a patient who's had a good disease-free interval, carboplatin paclitaxel, I think, is an option. Temozolomide, an oral agent with very good CNS penetration and good tolerability, I think is also a nice option for patients and allows them to stay out of the infusion center and generally with good tolerability. And lastly, PO etoposide, which I often dose at 50 milligrams flat dosing continuously, I think is another good option for patients that for whom you want to continue therapy, but perhaps performance status is inadequate for a clinical trial, for example. Some of the clinical trial directions that we're looking at include PARP inhibitors. These cells are highly mitotically active, prone to DNA errors, and have increased PARP dependency. Some of the PARP inhibitors are particularly good PARP trappers, holding the PARP machinery on the DNA strand. Therefore, when the replication fork comes along, a DNA catastrophe leading to cell death. We at UCLA reported on talazoparib single agent activity of about 10%, and this can be augmented when given in addition to a low dose alkylator. Anna Farago reported on olaparib with temozolomide in 48 patients with an impressive 42% response rate. The duration of response and progression-free survival perhaps were still disappointing, but an area that we'd like to continue to look at. We have reported on our slightly different dosing of continuous talazoparib with especially low-dose temozolomide. Here's an early data snapshot, and accrual has continued. But at this point, 4 of the 8 patients are still doing well 4 to 8 months into treatment. Lastly, I wanted to talk about Anlotinib. This is a multi-targeted tyrosine kinase inhibitor. here tested in a randomized phase 2 trial, the Ultra 1202 trial in third-line small cell lung cancer versus placebo. Patients randomized 2-to-1, and progression-free and overall survival benefits were seen. I was able to find about 15 trials with Anlotinib that are currently accruing in small cell lung cancer, but nearly all of them in China. So it'll be interesting to see further development here. Thank you very much for your attention, and I look forward to questions.